The business of healthcare is hard, creating a badlands of terrain that is difficult to navigate. Some think the most brilliant minds in business are on Wall Street. They are wrong. The most brilliant minds are in healthcare. They have to be to thrive and survive. This podcast explores concepts in leadership, management, sales, and negotiation with those brilliant minds. The Healthcare Badlands podcast is generally planned, but unscripted, unedited, and uncut, so you get the honest and unfiltered experience. Your host is Dr. Tom McDougall, a 30-year veteran of healthcare with 23 years of hospital CEO experience. His guests are carefully selected experts from across the industry. They offer insights, expertise, and some great real-life, often hilarious stories. Now, let's jump into the episode.
Welcome to the Healthcare Badlands podcast. Very happy today to have Dr. Ian Kahane with us. Ian is an internal medicine physician in Florida. He's also built a very impressive practice called Complete Care. He is also the treasurer for the Manatee County, Florida Medical Society. So we're going to have a little discussion about that as well. But welcome, Ian. Glad you're here.
Thank you for having me, Tom. Happy to be here.
All right, let's jump right in. My first question for you is, you have built an impressive practice and it is very well balanced on excellent patient care, and you've also used innovation and technology. So talk about how you've approached this and how you built something from the ground up and have created a very sustainable model.
So I think people underestimate the power of being positive and kind. And I know that probably sounds corny, but I remember when I first started the practice 5 years ago, I had a gentleman, new diagnosis of ALS. I'm only seeing one, maybe two patients a day. And I just sat with them for an hour and a half. And anything that I didn't know, I went and read and I told them, hey, I don't know this. And then they came back and I went over it all with them again. And the next week I had 9 of their neighbors in my office. So really just being, as positive as you can, as kind as you can, trying to keep your science sharp, but still knowing your own limits. I think patients really perceive that, and then they want to be there and they want to do better by themselves and by the doctor. So then it kind of grows. And then the other thing that I think is so important too is culture. I always say, put the patients first, and then I think everything else follows. But the reality is, I think the culture of the office probably directs really a lot of the patient care. And what I mean by that is me focusing on caring for my staff, making sure my front desk is happy, making sure my medical assistant's happy, making sure my other doctors are happy. Because if everybody in the office is happy, they're going to treat the patients even better. And we just then can reverberate that message of positivity and kindness and integrity to the patients. So I think figuring that out is, let's have that positive culture, because I have to see all these medical assistants and doctors and front desk all day, every day. I have to see the patients for 15, 20 minutes. So let's get this positivity sphere going. Then that's going to translate into the patient rooms, and the patients are going to want to be a part of it.
Okay, so about culture of your team, I'm curious from what you said. Culture can be created really 3 different ways. One is the culture of hiring. So you've got to hire the right people to begin with. The second is that you create this kind of appetite for people to be kind to each other. So they almost learn it by watching others. And then the third piece is training. So of those 3 areas, where would you attribute your most success to creating this great culture?
Number 2, lead from the back. I park the furthest away. I don't have a doctor's parking spot right at the front of the building. My parking spot is literally as far away from the front door as it can be. I also have the smallest office in the whole building, also deliberately. I want them to see me as part of the trenches. I am a very busy physician, seeing 30 plus patients a day on top of trying to run a business. I still sometimes answer the phone, and I still sometimes clean the toilets. I think creating that culture of, we're all in this together and we're going to do great, and everybody still has their role to play, but we're all in this together. Let's advance together. I think that's just a huge way to create that positive culture. And yeah, I do think it's smart hiring and it is training. Absolutely. I definitely engage in a reasonably rigorous interview process anytime I have to hire. But it's just, I exude that positivity and kindness. I demand that of the senior management. And then I think it just spirals down from there.
That's fantastic. So, all right, curious question though, because you started this discussion about that you spent hour and a half with this patient and then you get his 9 neighbors, but now you're saying 30 to 40 patients a day. So we can all do the math. There's no way you're spending an hour with each patient. What strategies do
Correct.
you use to make the patients feel like they have your full attention and that you have given them a lot of time?
That's definitely an art, what you just said. And I talk about it occasionally with some patients is how do you in a 10 or 15-minute visit make somebody feel like they're the whole world. And it is definitely a trick. I think it's making sure that they get all their questions out, making sure that they feel heard. And then it's also, I think, smart scheduling. So I don't actually accept new patients anymore. But when I was still accepting new patients, they were the last of the morning or last of the afternoon. That way, if I had to spend an hour with them or an hour and a half with them, I could. That first visit being much longer, then what would happen is now if I need to only take 5 minutes, they understand because they're like, oh, if I really need Dr. Kahane, he's there. And when I have a patient who is really sick, diagnosed with something terrible, I will actually still give them an hour or an hour and a half and sit with them. And again, that's smart scheduling. So I have a couple patients, they have to be the last of the morning or last of the day because they're schmoozers and they want to talk to me for a long time. So I think it's that having that smart schedule, and every once in a while, one of the schmoozers gets in at 8:15, and I go to my front desk and I go, "Uh-oh, we forgot about our chart alerts here. I'm going to be behind now. We need to look at this. Can I get the 8:45 to come in at the end of the morning? Because there's no way I'm going to be able to do this appointment in 15 minutes." So I think it is smart scheduling, and I think having that initial visit be so thorough that subsequent visits they're willing to let be less.
Okay, so in your EMR, do you have a checkbox next to the name that says schmoozer versus non-schmoozer?
Well, so we're a little more polite than that. It just says must be last of morning or must be last of day. But it's essentially this person's going to talk. My favorite thing, there's an ICD-10 code that says verbosity is obscuring the reason for contact. I love putting that diagnosis code on people's charts. If they are tangential or talkative, if it's a longer visit, I'm like, Medicare should know that that's automatically, I get to upbill this because I am having to deal with a lot more than their healthcare whenever I put that verbosity obscuring the reason for contact diagnosis code on someone's chart.
That's awesome. And the listeners just picked up on a little coding secret. I like it.
Yes, yes, that is definitely a good coding secret. A lot of people don't know about that code, but I think it's a great one.
Yeah, that's really good stuff. All right. So let's switch gears just a little bit. I want to talk about the fact that you've kind of bucked the trend a little bit, where a lot of primary care physicians have chosen employment, but you did the exact opposite coming out of your residency, where you decided you were going to create something brand new and be fully independent. So what went into your decision process in that? And how have you proven successful with that, where a lot of people are just choosing the employment route?
You know what? I had a couple doctors call me crazy, actually. Like, why would you do that?
I
That
would
seems
never say
nuts.
that out loud. Never.
Yeah, yeah, there were doctors that did tell me that, believe me. But I have a business background. My family owns a couple different businesses, and I think physicians tend to be very intelligent people who just no business acumen whatsoever. So if you have a little business acumen and you're willing to push the insurance companies a little bit, I think you actually do better by working in smaller private practices, certainly in primary care. Groups I think of 2 to like 10 physicians. I think the physician quality of life is going to be better. I think the patient quality is better. The patient care is better. So you get to run it the way you want to. I've had a lot of people join my practice, the 5 physicians that I work with now who have worked for bigger companies, and they all say, my God, this is so much better. They're making more money and working less, which is a good combination. Usually when you hear that, you assume somebody's lying to you, but that's what's going on in my practice. So I think even though the trend over the last several decades has been more and more employed physicians, because physicians are very smart people with no business acumen whatsoever. I actually think the trend is going to start shifting the other way because most of the physician groups are complaining about how these very large organizations are hurting medicine or causing physician burnout. And I can tell you, I don't think any of my physicians feel even remotely burnt out. I work very hard and I don't feel a little bit of burnout either.
Yeah, well, you're very passionate, and that offsets the burnout extremely
Sure,
well.
sure.
Yeah, just recently in the last few years, I'm hearing more and more physicians cool on the whole concept of private equity. I don't know if it's just kind of working its course, but it seems like 5 years ago there was a lot of interest in the dollars associated with private equity, but now it sounds like to me that physicians are leaning away from it as opposed to leaning into it.
I think a lot of the smaller groups that were brought out by private equity regretted it later. I do know doctors who have done that. The other thing too, just because of my father works in investment banking, and he actually got his healthcare private equity guy. That's all he does is buy small practices, tries to make them larger. And I spoke with him. He had even said to me, "Don't do it. If you have 50 doctors, it's probably worth you selling out. But growing organically and growing a practice, you'll be a lot more successful, and you won't want to sell out to private equity until you're ready to retire." So I said, "All right, I won't do it." So even an investment banker I trusted said, "It's just not great. They just, I think, cut a lot of the things that makes healthcare great, and it's an error."
Yeah, I heard somebody say one time, and I thought, you know what, that makes a heck of a lot of sense. They said the first private equity deal is not the problem; it's the second private equity deal.
Sure.
That a lot of physicians are happy with the first one, but the model of put together, a certain amount of Medicare lives or a certain number of physicians, and then you package all this up and sell to somebody else, and that second group is the one where things start going kind of south in terms of culture as well as happiness of the physicians.
You know what? If they're cutting too much, that can be a problem. And trust me, I'm a very big believer in wealth is not an income error; it's usually a spending error. You spend your way to success or poverty, and so I run the business very leanly. But if I need to buy something, if it would make somebody in my practice much happier, I of course am going to do it because I look at that value. If they want something, they want a $20,000 boat, that's not going to happen. But there's a lot of little things that we can do that add value, and when you bring in those private equities, they don't get it. A lot of times they think having a pizza party one Friday a year is sufficient, and it's just not usually.
Great point. I like that. All right. And one of the reasons I invited you to join me on the podcast, and you know this, is you have built a really impressive practice that a significant core of that practice is medical weight loss, Ozympic, and some of the others. So talk about what you've built, and then I'm going to have some questions for you about that.
Sure. I tell a lot of my patients half of the medicines that I prescribe on a regular basis are good because people don't want to eat right and exercise. Now, the other half are real conditions, Parkinson's disease or depression, multiple sclerosis, things that are out of our control. But there are so many people that just don't want to eat right and exercise. And it's partly a shame, but it's also partly a disease. I actually struggle with my weight. I'm 6 feet tall. I was 300 pounds at one point, and I
Wow.
lost it before all these medicines came out, with diet and exercise. And I'm just really passionate about weight loss. And several members of my family struggle with weight. I still struggle with it on a regular basis, so I get it personally. But these medicines like Ozempic and Mounjaro and Wegovy and Zepbound, they really are just game changers how they work. And I really feel like I'm reversing disease by getting people to change their way of eating. And by doing that, making them healthier, making them feel better, making them happier looking in the mirror. And when they get all those things, it just makes me feel good. They actually wind up seeing me less, but again, I'm a busy guy, so that's okay. But I'm genuinely happy that they're healthier. So I have just loved it, and it's definitely been a core focus. I wouldn't be shocked to learn that I wrote 30 or 40 of those prescriptions this past week. And again, for a branded drug, that is an absolute ton. My non-branded drugs, I probably do that, but the second place branded drug is probably 2 scripts per week. So to be doing 30 and 40, it's definitely a very big part of my business.
Where is the compounded pharmacy in this? Because there's been some discussion of that, particularly with some of the publicly traded companies that they're using compounded drugs as opposed to name brand. Where do you fall on that?
I'm perhaps an extremist, and I'm usually a radical centrist, actually, with most of my views, but I'm an extremist in this situation. I'm really against the compounding pharmacies, and the biggest reason is I have just seen disasters. Most patients are getting too little, and there's actually a couple studies showing, like Eli Lilly and Novo Nordisk bought compounded drugs and tested them. Most patients were getting way less than the dose that they were told. A lot of them are actually designed so that way you can't even figure out what the dose is that you're getting. And then I've also seen patients where unfortunately the medicine settles out and they get way too high a dose and wind up in the emergency room. The thing is with a name brand Mounjaro or Ozempic is I know exactly what's in it. I know the inactive ingredients, and there's a lot of rigorous controls on it. The medical spa ones, while I appreciate that there might be more accessibility to them, particularly a year ago when these drugs were much more expensive, it probably had a role in helping people that really couldn't afford it. But nowadays, Wegovy and Mounjaro have dropped so much in price. Wegovy was running a special right now, $199 a month for the name brand medication, which is great. And then I know what my patients are getting, so I just feel very comfortable with it. I have been very against the medical spas. Of the ones that I know, and I'm sure you might know more than me, but of the ones that I know, most of them were just giving people way too low a dose, charging them what seemed like a reasonable rate, $99 or $109 a month, $199. And then they would just keep them kind of stretching along forever. I could get you to lose all that weight in 3 or 4 months on the right stuff and then keep it off. Yes, it was more expensive per month, but after a couple months, you might be done. Whereas these medical spas come for every day for 5 or 6 years to get your 1/100th of a dose of Ozempic. And yeah, you'll lose a pound or two a month, but it just wasn't the way these meds were meant to be used.
How do you set expectations with the patient? So if you just have Sally Joe Jones that comes to you, makes an appointment, says, "Hey, Dr. Kahane, I heard you did this. You did it for one of my neighbors. I want to go on, weight loss medication." How do you handle that?
So I talk about other weight loss medications too. There are still pills that have been around forever. So I present that as an option. If they can afford the weight loss shots, a lot of times I'll have samples in my office. So I teach them how to do it because I want to make sure they can do them correctly. And then, I'll write it for them. But I do set up the expectation of I want you to come in every 3 months. And there's a reason for that. My first visit is all about the medication. My second visit is all about diet and exercise. There is a number floating around, and there's a couple studies now that show a number around this. 66% of patients, when they stop the medicine, regain all the weight. In my practice, that number is below 40%. And the reason being that second and third visit, I'm really talking about we need to make a diet and exercise change that's permanent. And the best diet is the one that you can follow. And I can talk about tons of different diets with you if you want, Tom. We could probably do a whole podcast on that. But the reality is you got to find one that's realistic that you can stick with 350 to 355 days a year. You only live once, so I want you to enjoy, right? On your birthday, I want you to have half a cake. But the day after your birthday, you can't have a slice of cake every day for the next 4 days. So it's just about enjoying, but not enjoying every single average Tuesday just because you said so. So that first visit really talking about all the advantages and pitfalls of the medication. And then I use the second, third, fourth, fifth visit, however many, really honing in on that diet and exercise regimen. And when patients listen, they're successful. I have had patients on the second, third, fourth, fifth, sixth visit, make so many excuses. I'm losing weight. I'm feeling good. Oh, I just have a little pineapple juice in my tequila on Fridays. Oh, I just, have a half a slice of pizza on Sunday mornings. And I warn them, I go, the second we stop the medicine, you're going to be putting all this weight back on. And invariably they do.
Well, I could see how a tequila flavored oral medication for weight loss could be very successful. Maybe that's your next venture.
That would probably be very successful.
All right. And
it'd have to make you a little tipsy too, though.
Yeah, good point. I recall back when these weight loss medications were really getting a lot of press and they were starting to become more popular and patients were starting to go to their physician office and ask for them. I had a moment when I thought to myself, wow, how's this going to impact the bariatric surgery industry? And the comparison I would use is that the growth in structural heart procedures, where in a cath lab you're doing valve replacements and other things that previously were a cardiac surgeon, open heart type procedure, are now performed in the cath lab. And that has had a long impact, and I think a permanent impact on reducing the number of patients that have an open heart procedure. So the thing that was popping in my head was, will the weight loss medication industry displace and significantly reduce the number of patients that are having bariatric weight loss surgery? But what's your take on
I'm not
this?
100% sure. Yeah, I'm not 100% sure, but what I would say, continuing your analogy, when we used to replace aortic valves, it was a major decision because you had to crack open somebody's chest to do it. You waited until the patient was extremely symptomatic or they had some other devastating finding on the echocardiograms. Nowadays, because it's a quick procedure where you're going through the leg and just deploy a new valve over the old valve, patients go home 2 hours later, 4 hours later, the same day. Obviously, I'm making it sound a little more simple than it is. I'll give the interventional cardiologist more credit. It is more technical than that, but it's much easier than what was with cardiothoracic surgeons. So the number of people that are getting the surgery went up. I still do have patients that wind up needing to have their chest cracked for an aortic valve repair for various reasons. But because a lot more physicians, I think, got comfortable with the idea of replacing an aortic valve, there's a lot more discussion around it. And therefore, a lot more people are being helped by having that procedure. Going to weight loss, I think it's the same thing. I think all doctors talk about weight loss with their patients, but how many actually did it? And then when would that conversation move to bariatric surgery? Almost never, unless the patient brought it up to the doctor. Because I'm doing so many weight loss discussions now, when I have a patient who fails an Ozempic or a Mounjaro, and we've tried a lot of different stuff, now that's in my algorithm is, all right, listen, we tried Ozempic, we tried Mounjaro, they didn't work. You lost 10, 20 pounds, that weight came back. I've talked to them about diet and exercise. Something isn't sticking. I've tried other weight loss medicines. And that's when I text one of my good gastric bypass buddies and I say, hey, why don't you evaluate this patient? We've tried for 2 years. So I am certainly still referring. I have 3 patients in the last 6 months who have had bypass surgery. And I would tell you, I think that's up from what was 5 years ago. So I do think there are certain people that might have progressed to bariatric surgery that now Ozempic or Mounjaro will preclude that from occurring. But I also think there are going to be people who will try it, and now there's an increased amount of referrals for failures. And I also think, depending on the practice, and again, hopefully lower in my practice, there are people who are going to lose 100 pounds on Ozempic and Mounjaro. They're going to feel so amazing. They can't believe how good they feel. For one reason or another, they're going to wind up stopping the medicine. The weight's going to slowly climb back, and they're going to go, I don't want this. I don't want to be overweight again. And then they're going to say, please refer me to a more permanent solution. And a lot of times, gastric bypass surgery is that solution. And the last little thing I'll also say on the subject, I have also had patients who have had gastric bypass surgery, and 5, 6 years later, they start regaining weight. I put them on Ozempic and Mounjaro, and that gives us more time. So sometimes medicine is just, how can I buy another 5 or 10 years of the desired outcome, which in this case is weight loss? And I think sometimes bypass surgery and these medicines work synergistically.
Okay, so let's jump to the news stories out there that the patient stops taking the medication and all of them gain all the weight back. Is that been your experience, or what have you actually seen?
Yeah. So again, I think that number is 66%. There's some studies that say 70%. In my practice, it's like 40% of people regain the weight. What I usually tell most patients on that second visit is
So you're talking
there's a
about
reason why the gym
40%. You said 40% after they stop taking the medication, they regain the weight.
after they, in my practice, which is
Got it.
lower than nationwide, but a lot of people do still gain the weight. And again, I think it's just compliance, like anything, right? A pill, a diet. I used to hear before these meds came out, people would be like, oh, I lost so much weight on keto, but the second I stopped, the weight came back. And my response to that was always, duh. If you treat your mouth like a garbage can and then you put a restriction in place and you lose weight and then you remove that restriction and you go back to garbage can mode, you're going to put the weight right back on, right? So it's the same thing with these shots. Is I like to use these shots more as a springboard to lose weight, and then we carry it forward in perpetuity with diet and exercise. And I have had people who lose seriously 50 pounds, 100 pounds. I have some people losing 150 pounds on these meds. And then they stop them, and 3 years later, they're still down 145 pounds. I do have patients that, stop the meds, they gain all the weight back over 6 months. But what I was saying earlier, the big crux of it is the gyms are filled in January and they're empty by March because everyone's New Year's resolution is I'm going to go to the gym more. And the reality is that's just too vague to build a habit. If instead your New Year's resolution was I'm going to go to the gym on Monday, Wednesday, and Friday for 45 minutes, and I'm not allowed to go to bed on Monday, Wednesday, and Friday until I go to the gym for 45 minutes, then what happens in March and April when you get a little tired of it, you just kind of push through it because you're like, okay, this was my resolution. I'm really going to do this. And by May or June, now you've built that habit. You just leave work on Monday, you go to the gym. You don't even think about it. It's not a chore. It's the routine. On Monday, Wednesday, and Friday, I go to the gym after work. So if we build that good habit, we build that good routine, it will carry forward. Same thing applies with diet. Wegovy, Ozempic, Mounjaro, all these weight loss shots, they're the easy button. They give you time to experiment. Let's do keto for 30 days, bright line for 30 days, calorie counting for 30 days, any diet for 30 days. If you get to the end of the 30 days and you're like, you know what, this was a little more effort, but didn't feel like a second job, I could do this, then you're going to stick with it. And then that way, when we have to pull the medicine off for one reason or another, you have a habit of following keto and exercising, or doing calorie counting and exercising, and then that weight will stay off in perpetuity. But more people, I think, need to have those conversations early on. We're going to eventually replace this shot with diet and exercise. How are we going to do that? How are we going to be successful? And I think, unfortunately, a lot of visits are just, here's your shot, here's your shot. And some patients are on them forever. I do have patients who have been on Ozempic for 10 years, or just shy of 10 years. But, other patients, they go off of it after a year or two, and there needs to be a better game plan for keeping the weight off. And that game plan should be better diet and better exercise.
So am I hearing correctly that the medication creates the opportunity for the psychology of the lifestyle habits to kick in and stick? Is that?
Yeah, perfectly said, Tom. There is a receptor in the gut, and there's the same receptor in the brain. So these medicines work in two places, in the abdomen and in the brain. So it is just the easy button, and it's giving you that opportunity. You're eating so much less, you're feeling better oftentimes, and as a result, it gives you that opportunity. And some people can stay on these meds forever, but for certain people, they wane in efficacy over time, meaning that they just don't work as good as the years go on. Other patients, because of insurance reasons or cost reasons, have to get off of it. And again, if you're prepared because you are doing so much better 350 to 355 days a year, it's not that big a deal when you stop the shots. If you have lots of little exceptions, little pineapple juice and the tequila on Fridays, it's going to add up real quick.
Yeah. How do you coach the patients about alcohol consumption? Do you encourage them just to stop it altogether, or how do you approach that? Because the data's there. I mean, alcohol is sugar. So
Yeah.
that's counterintuitive to paying for medication.
So, ultimately, even though I know so many of us want to believe that a glass of wine a day is good for you, alcohol is a poison. It is not good for you. If you can give it up, you should. I drink bourbon once a month, maybe twice a month. So I do drink, I'll admit it. But, alcohol is a poison. Everybody has to pick their poisons. But the reality is, if you can give it up, I think you'll be happier and healthier. But I also, again, like you've heard me say earlier, I want to be realistic. Eating and drinking is one of the great pleasures in life. If I take it all away from you, you're not going to do it. Or if a diet and exercise regimen feels like a second job, you're not going to stick with it. So I want to find that happy balance. I actually think sometimes nutrition in general misses the boat, because a lot of nutritionists will recommend eat 1,200 calories a day, run 10 miles a day, be the perfect balanced triangle. And while that is actually probably the healthiest thing to do, it's just not realistic for 80+% of the population. So that's why I usually counsel, let's try different things and then find something that is more effort than what you're currently doing that got you into this mess in the first place, but doesn't feel like that second job. Because if it's a second job, you are going to fall off that wagon real hard and real soon.
Yeah, That's an excellent point. Yeah, I saw a sign outside a restaurant one time. It said, research has proven that 2 glasses of wine per day reduces your risk of giving a crap.
Yeah, that
I
sounds
thought,
about right.
I thought that was good.
Yeah, Ben Franklin said, "Beer is proof that God wants us to be happy." So, I get it. I rather eat my calories than drink my calories. That's my problem. That's why I struggle with weight. But, again, good diet and exercise definitely makes a good difference.
This episode is sponsored by CO Management Solutions, a revenue cycle company you may not have heard of, but you need to hear this. There is little healthcare organizations can do about inflation-related expenses, but you can make sure you're collecting 100% of your revenue you have earned. CO uses AI and the latest technology paired with an efficient team to aggressively collect your hard-earned revenue at an attractive commission. Start today with a free analysis of what you are leaving uncollected and recover that revenue quick with CO. For more information, visit coms.com. That is SCIOMS.com. One thing that I mentioned at the beginning when I was introducing you is you're very involved with the local medical society. So talk about that organization in your area, because I've seen medical societies all over the country, but that is the most impressive one I've seen. So why does it function at such a high level, and how do you hold everybody together to really stay engaged?
Yeah, I think most of the physicians are into funding it. We have hundreds of physician members, so there's funding available. We actually have a really very dedicated director. Her name is Valerie. So she is an absolute workhorse to making sure that things are getting done. It's really a full-time job that she has. So I think a lot of medical societies have like one kind of part-time person, or maybe they're just asking the doctors to run it. We have a full-time director whose job it is to make sure that there are events and things that the physicians are interested in. And then the other thing that I would say is, in general, I'm a big believer in that 90% of the battle is sometimes just showing up, right? Policy is made by people who show up. So many people just choose to stay home. Not to hit the point home, not to change directions, but there are 8.8 million New Yorkers. There was just an election and 900,000 people voted, right? I know not all 8.8 million were qualified to vote in that election because it was a primary, but I think 3.5 or 4 million were. So only 900,000 showed up. The same thing is true in medicine, and a lot of things is policy. Everything in general is decided by those who show up. So I like showing up. I think there are a decent amount of doctors that like showing up. And then I think we have some driving forces in town that make it happen. And then the rest of the community, the people who don't on average show up, still want to come out to events, want to socialize, want to get referrals. So I think it's a good community. But yeah, I know because I see some of the neighboring towns where they have events and 9 out of the 400 physicians will show up. But our medical society, our gala last year had almost 300 people at it, more than half of which were physicians. So we're definitely getting good involvement.
Yeah, well, I mean, absolutely. I know your group, and you do socialize well. You do a good job of that. But is there a role with that same medical society in 2 areas? One is advocacy, really political involvement, and 2 is trying to make efforts to improve population health.
Yeah, so actually, our medical society has a super PAC, believe it or not. So we're definitely involved in politics, and not particularly backing one party, but more just lobbying for certain things like better patient care, better physician standards, ways to reduce physician burnout and scope creep, and those kind of things. So definitely involved with that. Our medical society actually sends a delegation. I'm in it this year, to the FMA, which is the Florida Medical Society, and they are just a giant lobby group. So we definitely are super involved with that. And then, yeah, we do use the medical society. We have wellness events. We also have a lot of things to try to help doctors. We have like a psychiatry program where if a physician is struggling, they can call and nobody knows their name. They just get assigned a number, and then they get 6 free counselings to try to reduce physician-associated suicide. So, it's just a robust program. We have CME events. So I think the robustness of our offerings, some things aren't perfectly attended, but some things we get unbelievable attendance to. I think having that robustness and that continuous engagement keeps everybody coming back for more.
Excellent. One thing you mentioned early in this, and then I just wanted to come back to with you talking about the counseling and some of the resources available to your members. Physician burnout has gotten some discussion, and we've seen some physicians burn out. I know some, you know some, we've
Sure.
seen it occur. How widespread a problem is that really among physicians? Because there's no metric or no measurement or no research out there that's really dependable on this.
I think it's huge. I see it pretty regularly. It's a shame because I love what I do, right? But sometimes the bar is just, do you care as a physician? And I think 50 or 100 years ago, like everybody that went into medicine cared. I always say I could have made more money on working on Wall Street, but I really love what I do, and I feel like I'm just doing a good thing every day when I go to work, that I'm helping humanity. When you talk to some other doctors, I do think they feel burnt out, and we could talk about the reasons why if you really wanted. I'm sure there's a lot, and it's mostly conjecture. But the reality is, I think it is a big problem, and I think it's going to be something that the medical community is going to need to face in the next couple of years, or patient care and the quality of patient care is really going to be declining.
Okay, well, let's talk about some of the reasons. What's contributing to this?
I think some of it is the big stuff we were talking earlier, like the big groups making unreasonable demands, right? I think it's also setting up unrealistic expectations. I almost brought in a neurology group into my practice one time that was going under. And immediately from the first conversation knew why they went under. Is all of them came in and said, we want to see 18 patients a day and make $500,000 a year. And I said to them, listen, if you want to hustle, you can make a lot of money, but 18 patients a day is not hustling. You have to choose one or the other. And they wound up founding a practice that gave them everything they wanted. They were offered plenty of money, and they only had to see 18 patients a day. And I said to them, you can take this offer, but the reason why your current practice is failing is because that doesn't work. You are going to, in 2 or 3 years, have to see 50 patients a day to keep this number going, or you're going to take a huge pay cut. So why set yourself up for failure? So I think there's unrealistic expectations, particularly from very large groups. They promise the doctor everything, and then 2, 3 years later, it all gets cut or is not delivered. I also think some physicians are worried about scope creep, which is nurse practitioners and PAs kind of overstepping a little bit, which a lot of times makes our job harder. It certainly has made my job harder on a regular basis. And I also think there are a lot of doctors that go into it for the wrong reasons. So their parents push them to do it, or their father was a doctor, or their mother was a doctor, so they need to be a doctor. And the reality is, if you're not passionate about it, becoming a physician is a very long road. So you have to love science, you have to love the idea of patient care, and if you don't, you're going to get burnt out quickly. So I think trying to address some of these things would reduce physician burnout, but I don't think any of them are being addressed right now, really, or if anything, they're getting worse.
Yeah, and it worries me when I hear physicians or I hear young people say they want to be a physician, and when you start asking them the questions and they get it real with you, they say, well, because of the money. But I'm a weird person because I considered going into medicine as a profession, and decided not to because of the economics. The amount of time you have to invest to become a physician is substantial. And
Yeah.
I've known a lot of people who have come out of their training and they're about to start working. And, I've recruited a lot of doctors over the years. It was not unusual for me to hear a physician say, well, I've got to get to work because I have $250,000 or $400,000 in debt and I've got to pay all that back. And I thought about that in advance. I just don't know if people are being prepared for that it is an
They're not. They're
enormous
not.
investment. And the days of getting extremely wealthy as a doctor, they're not there unless you're just absolutely going to work yourself hard.
You know what? It's not only $400,000 in debt, but you also have to realize you become an attending physician at age 28. Your friends started working at age 21, maybe 22 if they went to college, or maybe even younger, right? So if they're making $80,000 a year times 7 years, you're behind that number too, right? So a lot of times I've read books where they call it the $1 million mistake between the student loans and you didn't make money for 6, 7, 8, 9 years, sometimes longer depending on your specialty. It is definitely negative. And I think if you're going into medicine only for the money, it's going to be problematic. Physicians do well, unmistakably. But I think if you're very money oriented, there are a lot of other businesses working on Wall Street, a lot of other ways that you can do better. I had friends that were physics majors at good universities that at age 21, 22 got very high paying investment banking jobs and made as much as I did as my first year as an attending. So again, if you're intelligent, there's a lot of other options. I went into medicine and I'm very happy I did, and I would recommend it to anybody else. And I know not all doctors feel that way right now. I do love medicine. I would recommend it to the younger generations, but I love what I do on a regular basis. I feel like I'm making a difference. And even if I didn't get paid, I would enjoy it, 95% of the time. That's, I think, the right attitude in medicine. When people go in it for money, they are miserable the whole time.
Well, everyone who has listened to this episode knows your passion. It comes through with you, and we're really lucky to have you as a physician. I know how lucky your patients are. So thanks so much for joining me today.
It was a pleasure, Tom. Thank you. Happy to do these anytime.
Thank you for listening to the Healthcare Badlands podcast. As always, please like and subscribe so you don't miss future episodes. If you have suggestions for topics or guests, please email those to podcast@badlands.pro. This podcast is for informational and entertainment purposes only and should not be considered legal advice. Some information shared may include fictitious names. The opinions expressed are solely those of the host and/or guests and are their own and not reflective of the opinions of others or our sponsors. Thanks again for listening, and we hope you'll join us on the next episode of the Healthcare Badlands podcast. Until then,